Bipolar disorder is a mental disorder characterized by periods of depression followed by abnormally elevated moods and vice versa. If the elevated mood is severe or associated with psychosis, it is called mania. If it is less severe, it is called hypomania. During periods of depression, individuals may experience crying, a negative outlook on life, and poor eye contact with others. The risk of suicide is high. Over a period of 20 years, 6% of people died by suicide. During mania, an individual behaves and feels abnormally energetic, happy, or irritable. Bipolar disorder is characterized by unpredictable swings in mood from mania or hypomania to depression. Sometimes, some patients suffer only from recurrent attacks of mania, which in its pure form is associated with increased psychomotor activity, excessive social extroversion, decreased need for sleep, impulsivity and impaired judgment, and expansive, gradual, and sometimes irritable mood. In severe mania, patients may experience delusions and paranoid thinking indistinguishable from schizophrenia. The mood fluctuations are chronic and should be present for at least 2 years before the diagnosis is made. And in mania period, a distinct period of abnormality and persistently elevated, expansive or irritable mood, abnormally and persistently increased goal-directed activity or energy, lasting at least 1 week and present most of the day, nearly every day. Number 1 is the inflated self-esteem or grandiosity. Number 2, decreased need for sleep, such as feels rested after only 3 hours of sleep. Number 3, more talkative than usual or pressure to keep talking. Number 4, flight of ideas or subjective experience that thoughts are racing. Number 5, distractibility, such as attention too easily drawn to an important or irrelevant external stimuli, as reported or observed. Number 6, increase in goal-oriented activity, either socially, at work or school, or sexually, or psychomotor agitation. For example, purposeless, non-goal-directed activity. Maniac episodes typically emerge over a period of days to weeks, but onset within hours is possible, usually in the morning or early morning hours. An untreated episode of either depression or mania can be as short as several weeks or last as long as 8 to 12 months. Furthermore, hypomania is the milder form of mania. Some people who experience hypomania show increased creativity while others are irritable or demonstrate poor judgment. Bipolar people who experience hypomania tend to forget the effects of their actions. Symptoms of the depressive phase of bipolar disorder include persistent feelings of sadness, irritability or anger, loss of interest in previously enjoyed activities, excessive or inappropriate guilt, hopelessness, sleeping too much or not enough, changes in appetite and or weight, fatigue, problems concentrating, self-loathing or feelings of worthlessness, and thoughts of death or suicide. Sudden onset and resolutions of symptoms, significant weight gain or loss, and severe episodes after childbirth. The causes of bipolar disorder likely vary between individuals, and the exact mechanism underlying the disorder remains unclear. Genetic influences are believed to account for 73 to 93% of the risk of developing the disorder, indicating a strong hereditary component. And psychosocial factors play a significant role. In surveys, 30 to 50% of adults diagnosed with bipolar disorder report traumatic or abusive experiences in childhood. Bipolar criteria and subtypes. The DSM and the ICD characterize bipolar disorder as a spectrum of disorders occurring on a continuum. The DSM-5 and the ICD-11 list 3 specific subtypes. First is the bipolar I disorder. In here, at least one maniac episode is necessary to make the diagnosis. Depressive episodes are common in the vast majority of cases with bipolar disorder 1, but are unnecessary for the diagnosis. Specifiers such as mild, moderate, moderate severe, or severe. By the bipolar II disorder, no maniac episode and one or more hypomaniac episodes and one or more major depressive episode. Hypomaniac episodes do not go to the full extremes of mania. For example, do not usually cause severe social or occupational impairment and are without psychosis. And this can make bipolar II more difficult to diagnose, since the hypomaniac episodes may simply appear as periods of successful high productivity and are reported less frequently than a distressing, crippling disruption. Third is the clichythymia, a history of hypomaniac episodes with periods of depression that do not meet criteria for major depressive episodes. The precise mechanisms that cause bipolar disorder are not well understood, but meta-analysis of structural MRI shown that certain brain regions, such as the left rostral anterior cingulate cortex, frontoinsular cortex, ventral prefrontal cortex, and claustrum, are smaller in people with bipolar disorder, whereas others are larger: the lateral ventricles, globus pallidus, subgenual anterior cingulate, and the amygdala. So now, what are the possible treatment of this disorder? The aim of management is to treat acute episodes safely with medication and work with the patient in long-term maintenance to prevent further episodes. First is the psychosocial. Psychotherapy aims to assist a person with bipolar disorder in accepting and understanding their diagnosis, coping with various types of stress, improving their interpersonal relationships, and recognizing prodromal symptoms before full-blown recurrence. Medications may differ depending on what episode is being treated. The medications with the best overall evidence is lithium, which is an effective treatment for acute maniac episodes, preventing relapses and bipolar depressions. Lithium reduces the risk of suicide, self-harm, and death in people with bipolar disorder. Antipsychotics and mood stabilizers used together are quicker and more effective at treating mania than either class of drug used alone. Some analyses indicate antipsychotics alone are also more effective at treating acute mania. Mood stabilizers are used for long-term maintenance, but have not demonstrated the ability to quickly treat acute bipolar depression. Lithium carbonate is the mainstay of treatment in bipolar depressions, although sodium valproate and carbamazepine, as well as a number of second-generation antipsychotic agents such as aripiprazole, asenapine, olanzapine, quetiapine, risperidone, and ziprasidone also have FDA approval for the treatment of acute mania. Lithium and the anticonvulsants carbamazepine, lamotrigine, and valproic acid are classed as mood stabilizer due to their effect on the mood states in bipolar disorder. Lithium is preferred for long-term mood stabilizations. And lastly is the prognosis. Bipolar disorder is a lifelong condition with periods of partial or full recovery and between recurrent episodes of relapses. Bipolar disorder is considered to be a major health problem worldwide because of the increased rates of disability and premature mortality.